Welcome to an In Conversation With. My name is Emma Smith, and I'm delighted today to be in conversation with Professor Claire Surr, who's the Director of the Centre for Dementia Research at Leeds Beckett University. So, Claire, thank you so much for giving your time today.
Very welcome. It's good to be here.
It's good to have you here. So our plan for today is I'll give you a little bit of background about Empowered Conversations. I'll hand over to you for your presentation, and then we'll come to questions at the end. If you have any questions, you should just have a little question mark in a bubble at the bottom of your screen, so you can just press that and drop the questions in there. Okay, so a little bit of background about Empowered Conversations. As I said, my name is Emma Smith. I'm the project manager with Empowered Conversations. We deliver communication courses to family caregivers of people with dementia. So we deliver empowered conversations and moving beyond words across Greater Manchester for family caregivers, and we also deliver it to professionals. We offer one-to-one dementia-focused therapeutic support for family caregivers through Empowered Carers, and every so often we pop up and do a little webinar like this. I think that's probably all I have to say. So Claire, I'm going to hand over to you, if that's okay, to start the presentation.
Right, so hopefully you should be able to see that.
Yep.
So what I'm going to talk about today is about a study that we carried out in cancer services, and looking at how cancer services could improve their support for people with dementia. I'm going to give you a very sort of brief overview of what we found, but what I really want to talk about then is how we've then put that research into practice, because I think sometimes what you get in research presentations is this is what we found, and often it's just as studies have completed. And there's not always a clarity for people around, well, what difference does that research make? How is it, making any difference? So we're a couple of years beyond the end of that study now, and I thought it was quite nice to share some examples of actually how we've taken research out into practice and how it's making a difference within services. And my colleague Rachel, who is also on that slide, contributed to, she was one of the research team, but she had a lot of input into writing this presentation as well, because we've delivered it somewhere else as well, or a form of it. So thanks to Rachel for some of these slides. So why did we want to look at dementia in cancer care? Well, part of the issue was we know that as people age, they are more likely to develop dementia, and they're more likely to develop cancer. So that made sense to us that there would be quite a number of people who have both cancer and dementia. And obviously those are quite big diagnoses. And we thought that maybe dementia would complicate people's experiences of cancer. And when we looked in the literature, there wasn't really much out there. There wasn't any clarity on actually how many people with dementia had cancer, or how many people who have cancer also have dementia. And there wasn't much about people's experiences of cancer services when they were living with dementia. So our research project looked at both trying to get some numbers around people who have cancer and dementia, using GP records, and doing a big sort of analysis of GP records, and then also doing some data collection in cancer services to find out about people's experiences. So what we found from our big data analysis was that 1 in 13 people, when they're aged 75 and above, if they've got a cancer diagnosis, will also have dementia. And actually the same numbers applied the other way around, quite by chance. But if you take anybody who's age 75 who's got a dementia diagnosis, 1 in 13 of those people will also have a cancer diagnosis. So it's quite a lot of people. This isn't an insignificant number of people. If you think about an oncology department and the ages of people who may be in that oncology service, 1 in 13 people in that waiting room who are age 75 will also have a dementia. And then in terms of our data collection in hospital cancer services, what we did was a combination of observing people's experiences. So our researcher, we recruited people who we knew were going to be attending the hospital department who'd got a diagnosis of dementia. Our researcher met them at the door of the hospital, and they stayed with them throughout their time in that hospital department, so in the waiting areas, in their appointments themselves, in any tests or treatments with that person's permission, and obviously not compromising anybody's privacy in those, and then to the point of leaving the hospital again. And then we also had conversations with them during that time and asking about their experiences, as well as some interviews as well then with the people with cancer and dementia, their family members who supported them, and members of staff working across different parts of hospital cancer services and in other departments that they might come into contact with. So we got 17 people who got cancer and dementia who were being supported by 22 different family members and 19 different members of staff. So we'd got nurses, radiotherapists, consultants. We talked to somebody who was in the patient transport waiting area, and healthcare assistants working in the department. So quite a range of people. And what we found was that cancer and dementia, having dementia brought a sort of an accumulated complexity to living with cancer. So these were two big conditions separately, but when we brought them together, it made people's cancer care much, much more complicated. We found it was more complicated in terms of making decisions about care and treatment. We found that it required the involvement of families and other supporters significantly more than it would for people who have a cancer diagnosis but don't have dementia. We found it meant that navigating cancer services was much more complex for people with dementia. We found that cancer services found it quite difficult to balance the needs of the person and the needs of the service. For example, cancer services are very driven by targets and processes and getting people through in a certain amount of time, and that didn't necessarily work for people with dementia who might need longer time, longer appointments, more time to make decisions and work things through. And we also found there were problems around sharing and understanding information. So often oncology services weren't aware somebody had dementia on their referral forms, so they might not be aware until actually the person walked through the door, or maybe not until partway through appointments and assessments. And often the information that came back from clinicians to the person with dementia and their family members wasn't well understood. So I'll just give you some findings, a brief overview of some of those. So in terms of them making the decisions about care, one of the key things was challenges involving both the family and the person with dementia. And obviously that needed to happen much more where somebody had dementia than if somebody doesn't. So the person with dementia might not understand their diagnosis as well. They might have problems making a decision. And so families were much more involved, or sometimes were the decision maker in deciding about what treatments, whether to have any treatment, what types of treatments, whether to undergo further assessments and diagnoses. So there was a lot of pressure on families to make these decisions in what felt like quite challenging circumstances. It was often difficult to understand and the explanations of treatment options, particularly for the person with dementia, and to weigh those up. And families often struggled with things like if it was a mum with a breast cancer diagnosis and mum might not remember that, what do I do about surgery? How, if she needs a breast removed, but she won't remember that she's had a cancer diagnosis, how is that going to impact her if she wakes up every morning and can't understand why her body looks different? Is that going to be really distressing? How are they going to cope with a stay in hospital if they need surgery? How do we weigh up whether somebody's going to be able to lie still for radiotherapy and distress them? And that, in terms of, well, what's the other options available to us, and how do I make that decision if I say no to treatment and don't think this is good for mum, dad, husband, wife? Am I making a decision that then means that person is going to have a shorter length of life? So these were really, really difficult decisions for people to make. And obviously a lot of cancer treatments have quite severe side effects. So there was often a weighing up of quality versus quantity of life. So often families and clinicians were supporting them to make decisions that were, this treatment might prolong your mum's life for another 6 months, but actually the the side effects of having chemotherapy might mean the quality of life that she's got for the time she's got left might be worse. So it was really difficult decisions, and clinicians often weren't sure either, and were trying to help families make their way through these difficult decisions. And sometimes family members didn't agree, so there might be two children deciding for mum, and one might say, we want to throw everything at her, we need to keep her alive as long as possible. The other one might be saying, well, I just don't think she's going to cope with this. You know, her quality of life is going to be poor. She's going to be distressed. And so that could cause real conflicts in families. So there were some real challenges in that decision making for families and for clinicians in offering advice around that. And often families look to clinicians to say, what do you think we should do? And so that was difficult for everyone. The sharing and understanding information, we found that, clinicians within the oncology departments generally hadn't accessed any dementia education or training. And this might be despite the clinicians being, in fact, both departments that we did this research in had really active inpatient work around dementia. So they'd been taking part in national schemes to improve their environments. We knew they'd got good training going on for inpatient staff, but the oncology departments were not aware of any of this and were not accessing any of this training. So they recognised that they didn't know enough about dementia to be able to provide the best care that they thought. As I've mentioned before, actually identifying and documenting dementia wasn't good. So referrals that came through from GPs maybe, and they were seeing people for the first time in the oncology department, might not, if there wasn't a tick box on that referral form that said, does this person have dementia, the GP might not write it in there. So that was a bit hit and miss. So often they weren't knowing a person's needs until they arrived. And sometimes family members wouldn't think to mention that, or the person wouldn't, because they'd think it was already in the medical records, which actually the oncology department couldn't access. Or if they could, it might be buried somewhere in their GP records, and actually they didn't have the time to be going through everybody's GP records in detail before seeing them. So sometimes it might not be raised at all, or the person might not acknowledge their diagnosis, and the carer didn't feel able to raise that in the appointment without sort of causing embarrassment. So it was quite difficult sometimes for clinicians to know, for that information about that person's needs to get passed across. And then often, even if clinicians tried their best to explain things, people reported to us, both the person with cancer and dementia and their family members, about feeling a bit in the dark. They didn't really understand the diagnosis, sometimes didn't understand what the different treatment options were, and sometimes things might be talked about in complicated ways. And certainly if it was, for example, an older couple attending, so a husband and wife attending together, we did find sometimes the spouse without dementia still had problems in sort of processing information and understanding what was going on, and they weren't able to report back accurately what had been discussed in appointments. So there was a real need all around for better sharing and understanding of information, both about the person with dementia's needs, but also for family members and the person themselves to understand better their diagnosis and their options and what was going on. And then this one around the balancing the needs of the person and the service. So we've got the radiographers here from the radiotherapy department talking about, allocation of slots and how, you've got a certain amount of time for different radiotherapy treatments. And actually, if a person with dementia is arriving for the first time, they've never been in the department before, and you've got to talk them through lying down, keeping still, and all those kinds of things. It can take twice as long as somebody else, and sort of having to balance that up and say, well, we need to give this person the time they need, but then that's more people sitting in that waiting room being delayed longer and longer for their treatment. So if they knew about it, and the radiotherapy form was the only one that had any tick boxes on when they were referred on to ask, does this person have dementia? Do they have mental health problems that might mean they would find lying still challenging? Have they got a learning disability, or other things that would mean keeping still and lying very still for radiotherapy might be more difficult? So they did have a bit of knowledge in advance and would try and schedule things, particularly if somebody was coming quite regularly for treatment, to meet that person's needs. But that was very reliant on their goodwill and their ability to do that. There wasn't a process for it. It was very much, staff doing that individually of, it's no good giving them the 9 o'clock time slot for an appointment because they've got to come on patient transport, and that means they're picked up at, they've got to be ready from 6:30 in the morning or something. So just understanding these individual needs meant they could be a bit more flexible. And what we found was they were really person-centred. They were very focused on the person and trying to meet their needs and trying to get people through the treatment if they possibly could, and doing whatever they could to help. So there was one gentleman who was living in a care home who needed radiotherapy for 4 weeks, 5 days a week, coming in every day. And the care home said, we do not have the staffing to send somebody with him every single day for 4 weeks on patient transport. That's pretty much a day out of a staff member's time. We don't have the staffing for that. The man didn't have any family members. He got a social worker. And so they managed between them to kind of bring him on the patient transport, and somebody in the department would meet him and sit with him and wait, and then they'd move him up the queue as soon as he arrived to get him in and then try and get him back out quickly. But it was really difficult, and he only got his radiotherapy because of the goodwill of the staff in that department and quite senior nurses sitting with him for maybe 2 hours while he was in the department before they could get him back to the care home. So that was some of the challenges of sort of making sure people had that support to have their cancer treatment. So as you can see, there were lots of interesting things that we found in our study. And we turned those into some practical ways that we felt services could improve the experiences for people with dementia. And we tried to make these really manageable things. There's obviously big things you can do, like restructuring departments and that kind of thing. But we tried to make these really practical ways, and we worked with the clinicians who were part of our research team to develop these, and our lay advisory group made up of people with cancer and dementia and family supporters to develop these. So we got simple things like, making sure hospital departments ask about, record and communicate a dementia diagnosis. You'd think that'd be easy, but no, not necessarily, because, in the medical records, particularly the electronic ones, to actually get any changes made in there, you have to put it through the software system. But one of our sites is actually doing that and was working towards having a tick box and trying to get that on the referral forms that come in as well, so that could be identified. We suggested providing sort of written information on the day that include pictures and personalised information about somebody's diagnosis, and maybe drawing where the tumour is, writing down about the types of treatment, and not just giving out either loads of leaflets or waiting for the letter to go out afterwards. Making sure family members were included in the appointments and checking with the person with cancer and dementia and the family member if they'd like a copy of any letters to also be sent to family members as well as the person, so that they were kept up to date. Where possible, to provide familiarity in staffing and the environment. So if somebody's going for radiotherapy every day, can you book them into the same room and with the same staff members, so that that's continuity and that familiarity that people can find helpful. Thinking about the environment and making it more dementia friendly. So even our researchers found it really difficult sometimes to actually find the way around the hospital. One of the sites is a brand new big cancer centre and was they just couldn't navigate their way around it. There were some places where there were some nice pictures on the walls that were like scenes from Yorkshire, and people using those to navigate. They're like, oh, that's the, whatever the Thingy Abbey or whatever, I recognise that, and they'll be, that's the corridor we go down. So they were also, I'll talk to you a little bit later about what the departments were trying to do around just navigation and making things a bit more accessible, signage, and trying to think about some quieter waiting areas for people with dementia, so they're not in those really busy places with lots of people coming and going. Recommendations about being flexible and trying to be adaptable as possible, obviously within the confines of what is possible within oncology services. Transport and arrival arrangements, these were massive. If people are coming on patient transport, I've already mentioned that, you know, they have to be ready from 2 hours before their appointment, sometimes even longer. They were always worried about whether the patient transport would turn up, would they miss their appointment? And once they'd actually had their appointment, and sometimes it might turn up even before that, so they might live 15 minutes from the hospitals and it'll turn up 2.5 hours before and drop them off. So then they've got to wait 2 hours in the hospital department before their appointment, have the appointment, and then go and check in at the patient transport desk and potentially wait another 2 hours for transport to take them home. Or they arrive by car, but if there's just you and the person with dementia, there's 2 options. You drive around, find a car parking space that might be miles away, and you've got to try and walk somebody who might not be able to walk very well and might not be feeling too well through a long journey to the department. Or you drop them off at the door, go and find your parking space and hope that they're there when you get back. You know, it was just often not practical for people within that car parking. So, you know, people were arriving in the departments really stressed because of the journey. And so we are doing some further research to look into that. And then the final recommendation was around training for staff within the departments, and making sure that they were able to be trained on dementia, and that they were also able to signpost patients and their families to appropriate support and other information. So what are the things that we've been doing? Well, the first thing we've been doing is sharing the findings. So we've been doing conferences and webinars for the last couple of years. We've presented at academic conferences, we've spoken at sort of cancer practitioner conferences and dementia conferences. We've written a number of journal articles to make sure things are out in the research field. And we gave presentations back to the staff working in the hospitals that took part in the study, and shared that with them at various sort of clinician meetings. And then we've been working with the hospitals and with others to actually find ways to implement this in practice. So one of the sites has been thinking particularly about its physical environment, and they'd managed to have a little bit of budget available to do some work around their physical environment. So one of the things they did was purchase some different coloured chairs to put in corridors, because there weren't any chairs and they realised the corridors were really long. They all looked the same. And so they thought, well, if we have maybe blue chairs in this corridor, green chairs in this corridor, red ones in that corridor, or whatever, we can tell people, you know, if you've got to go and have your blood test or an x-ray done or something, walk down the corridor with the blue chairs in it and turn left at the end, and then come back past the blue chairs when you're coming back to us. And it was really good for signposting, but also somewhere where people could sit and have a rest if they were finding the walking around the department difficult. So really simple things like that with a budget. They were looking into waiting areas and having some smaller quiet rooms and improving their signage, and have generally been sort of thinking about how they can make their departments a bit more sort of friendly for people. What else we've been doing is working with them to, so that one of the sites is developing a version of the Alzheimer's Society This Is Me document, which was designed for inpatient services. So the kinds of questions in it aren't really relevant for outpatients. So what they're trying to do is do a much shorter version of that people could bring into their outpatient appointments that say a bit about who they are, what their needs might be, and what might make any sort of care for them while they're in the outpatient department much easier, and that will give staff the information they need without having the person having to say it 15 times to 15 different clinicians that they might see in an oncology department. Yeah, and just thinking holistically, and the departments working to become more dementia friendly, and think how they can support people. So like the changes in the medical records and recording of dementia. I think just raising awareness amongst the teams, they've been so receptive, and that was one of the things we found really positive. We've not come across any oncology clinicians who've said, "Oh, we don't know why you're doing this research." We did when we started doing it. People said, "Oh, I'm not sure how many people with dementia we see." And actually, once we got the research going and they started looking for people, they realised they saw quite a lot of people with dementia, but weren't necessarily aware of them. And so we've had a very resounding positive feedback from clinicians saying this is something we need to do better and we can do better. And we've been asked to give a lot of presentations and share our findings and things with different hospitals and with cancer networks and things. So there's been a real positive reception from oncology services for this study, which has been great for us. We've written some articles for practitioner-focused magazines and journals like this one, and been providing materials to support delivery of dementia training to oncology clinicians. So there was a colleague who was providing the Macmillan training on dementia, so she was including some stuff about the findings from our study. And we know that as well it's gone into training that the local trusts provide to their staff. And the other thing we managed to do, so Leeds Teaching Hospitals was one of the sites that took place, and the big blue building at the front is Bexley, which is the big new cancer centre. And the pink building at the back is where the older people's inpatient wards are. And that's where Ali Raycraft, who is the nice lady in the picture, she's the lead nurse for dementia and older people's care in the hospital site. But she didn't know the oncology clinicians or any of the staff, and they didn't know she existed. And she is the person who provides all the dementia training. She's been leading the inpatient work, and she's really passionate and knowledgeable about dementia. So we've been able to link those people up, and they have within the trust, they have a dementia panel or group who lead the dementia work across the trust. And there are now representatives from the oncology department who sit on that, and they've been trying to get dementia champions within all areas of the oncology services with support from Ali. So just linking up people, you'd think in a hospital, people might know each other, but it's like any big organisation, they don't necessarily, and if they've not thought to ask, and certainly inpatients and outpatients are often very separate. So they weren't aware each other existed, or that there was some really good dementia training available in the trust. And then the other thing we've been doing is working more at a national level. So Macmillan have these guides for people with cancer and dementia and for carers, and they were revised a couple of years ago. So we inputted into some of the content that's gone into those revised guides. The Society and College of Radiographers have a practice guideline for their staff. So these are people who might take x-rays, or they might be delivering radiotherapy within the departments. And so they've, again, we're updating their practice guidelines. So there's quite a lot of our research within there in terms of what guides radiographer practice in working with people with dementia, not just in oncology departments, but right across hospital services. And then we've developed our own set of booklets that summarise the key findings for different audiences. And there's a link there at the bottom to where these can be found, and you can download them. We've actually got quite a lot of hard copies as well that we managed to get some budget to print. So we've been giving those to local NHS Trusts and the Maggie's Centre and things. But there's one for people who've got cancer and dementia or memory problems. There's one for carers, and then there's one for clinicians working in oncology services. And they're short little A5 booklets with kind of a picture on one side, and then our sort of findings and recommendations on the other, so that they're there for people to think about attending oncology services, and what questions might I need to ask, what might I need to take with me, what things should I think about. And then the same for clinicians in thinking about, if I'm working with someone with dementia, what's the sort of things I need to think about in supporting them. So they're freely available from our website. And then what next? Well, we've continued to work with the NHS Trust to implement the study. So Rachel, my colleague, who you saw the picture of at the start of the presentation, sits on the dementia board at Leeds Teaching Hospital Trust to feed into that work. We've been writing grant applications and doing further research, and I've got a couple of slides to just tell you about those ongoing studies. We continue writing up publications and sort of sharing our work in academic and practitioner fields. We've got things like the infographics that our university produced for us. So, for example, the slides I had with the different recommendations in those coloured boxes, they were infographics that our university developed so that we could share the findings in sort of engaging ways. And so we've got this growing portfolio of studies around cancer and dementia. So I'll just give you a little bit of a taster for some of these. So these are studies that are completed. These are 2 PhD projects. So Molly did hers on the experience and support needs of carers of people with cancer and dementia, and that's her publication there. So she interviewed carers of people who've got cancer and dementia. And one of the findings was that people really wanted peer support from other people and to know they weren't alone, because while it's quite a common combined condition, often people didn't know somebody else who was caring for somebody who'd also got cancer and dementia. And so she worked with Alzheimer's Society, and in their Talking Point online forum, there is now a specific forum that Molly set up around people with cancer, supporting people with cancer and dementia, and there's some Q&As from experts in the field and things, and sort of live chats that are ongoing there so people can get peer support. And then Olivia's was looking at people with cancer and dementia in nursing homes and how nursing homes support people. And one of her key findings was people often were not going to hospital to get a formal cancer diagnosis because they were too frail and it would be too difficult. And family members and GPs with care home staff were deciding it's too much for people. There's nothing to be gained by going to hospital to get a formal diagnosis, because they're not going to, they're not going to have curative treatment, and they probably wouldn't manage any palliative treatment, of radiotherapy or chemotherapy. But then it did mean that diagnosis was not well known by the nursing home staff. They weren't always sure whether somebody had cancer or not. And obviously then access to things like Macmillan nurses and the support of palliative care teams that might kick in when you get a cancer diagnosis, because that's what people say, one of the key things when people got a cancer diagnosis compared to dementia was you get a diagnosis of dementia and they say, come back when anything gets worse, come back in 12 months. You get a cancer diagnosis and everything kicks in, you get everything thrown at you, things happen quickly. And actually people didn't get the helpful stuff potentially when they were in a nursing home, because that diagnosis wasn't formal. It was more of a clinical diagnosis if we think these symptoms are suggestive of cancer. So there's concerns there around whether people's needs for symptom management and pain control are good enough within those services. And then we've got some ongoing studies as well. So Rebecca's currently looking at acute oncology services. So when people go into hospital and they may be on a 2-week wait, so that initial diagnostic phase where you get sent in very quickly with symptoms that might be cancer. People who are inpatients who might have a cancer diagnosed by accident when they're in for something else, or people who've got a cancer diagnosis and have problems with symptoms or side effects from treatment and might need to go back in quite quickly. They're looked after by acute oncology services. And so she's looking at how they support people with dementia. We've got Leslie, who is our PhD student who's actually the lead nurse for Yorkshire Ambulance Service, and she's looking at how they can improve patient transport services for people with dementia. So she's doing an ethnographic study where she's sitting on patient transport buses, following people around in their journeys across Yorkshire to different hospitals and their waiting and things. And obviously that's exciting because she works within the ambulance service, and so she can actually, they're really committed to making changes based on her findings. Then we've got a study that's ongoing at the moment looking at management and support of people with dementia in primary care. So we're interviewing GPs, practice nurses, community nurses, district nurses, and other people working in the community setting, looking at how they support people with cancer and dementia. And then a study that's starting in the new year is a broader one, looking more generally at outpatient services for people with dementia, and developing sort of an intervention toolkit that can help outpatient services become more dementia friendly and work better for people with dementia. So not just oncology, but optometry or wherever else people might go, because it's a really neglected area, and all the research has really been on inpatient services. So from that one study where we had the idea of, oh, cancer and dementia, I wonder what people's experiences are like, and if we could do anything, this whole sort of range of studies looking at different aspects of care, and that all leading to differences in practice for people with dementia has sort of emerged, and is ongoing. It's something that we're committed to carrying on forward. So that's me, really. That's the rest of the research team, just to acknowledge the people who were involved with us, including some of our co-applicants who were people who were living with us, supporting people with cancer and dementia, and our lay advisory group, and our funders. And there's the Leeds Beckett Twitter account and email address, but there's also, I haven't put mine on there, but I think they've been on all the advertising for this webinar. So that's me. So I'm open to any questions now. So I'll go back, I think, to this view.
Perfect. That was really interesting, Claire. It was so good to see how the research then led to some changes and then led to more research. It made me think. So yeah, if you have any questions, drop them in now, please, and we'll pick them up. So you're looking for a little speech bubble with a question mark in it. So if you drop them in there, we'll pick them up. Is the plan to go back to the hospitals where this has sort of been put into practice to see the so what? How's it made it better?
It is, and Rachel, certainly with Leeds, Rachel's in there very regularly, and we've got other research projects ongoing, and they will be taking part in the outpatient study as well. So it will give us a chance. So we've had less ongoing contact with Bradford because our lead contact there moved to a different post. But yeah, so we do know things are happening and have been taken on by that dementia board within the trust. The findings have been fed there, and it's their responsibility to implement some things like the record systems, and things can only happen through there. Whereas other departments like the radiotherapy department have been quite proactive, so they developed some dementia champions quite quickly, and we're moving stuff through. Obviously, COVID scuppered quite a lot of progress that people were making. We finished the study and were disseminating sort of just before COVID hit, and then that stopped things. And obviously, things are quite busy in cancer services at the moment in trying to catch up. But yeah, we do. It's not as easy as we'd like it to be, as it never is with impact. It's not like you can count how many vaccines you've sold or something like that when it's research like this. It's much more difficult to get a tangible, how many patients, what actually have you done as a result of this. But yeah, we are in there as much as we can, finding out what's going on, and are very much in touch with Ali and the teams there.
Fab. And this is a big question, how can we get it in every hospital?
I think we're trying in terms of, so we did speak at, we've been involved with the National Cancer Network, so we spoke at their events, and have been, there were a lot of people from the clinical networks there, as well as people from the local cancer networks that feed into their areas. So we've been trying to do it mainly through individual clinicians with a passion, really. I think it's because they're out, it's not something we could do, for example, a trial on, and and then prove that if you do this, it works. So it's more of a challenge to get it into practice, because it's not the traditional routes of, this thing is better than that thing, so you should now be doing this. Like to get it in the NICE guidelines or whatever. But I think that's the, you know, I think our work around outpatients as well, more generally, if we can get a toolkit that will work generally in outpatients, hopefully we can then do some work with that will apply both in oncology services but across outpatient departments in hospitals, because we think it's probably better to tackle things at that bigger level, because some of the stuff really is more systemic, that, you know, how you arrange patient appointments, or what goes out in letters and things like that, and how information goes to people, that needs to be across all outpatient departments, and not just, you know, it's how hospital systems work rather than necessarily how the breast clinic works or the prostate cancer clinic. So yeah, but mainly keen clinicians, but we've had plenty of them coming forward. So
that's brilliant. If there's any support we can offer to get it into Greater Manchester, then
yeah,
we will shout about it. And Phil's dropped a question in. So great to hear about the new ways of improving patient experiences. Could you say more about the practice guidelines on palliative and end-of-life care for people with cancer and dementia?
Palliative care and end-of-life care is not my area. I'm not aware there are any specific guidelines on end-of-life care for people with cancer and dementia. That is actually one of the areas that we're looking at as a potential next study, because we are wondering whether people may need different palliative care than somebody with cancer alone. So we're actually going to be doing a review to look at the literature on that next, to look at what's out there already. Yes, and Marie Curie, so I think the stuff around end-of-life care for people with dementia and palliative care, but I'm not aware of any that's about that. But that said, this is why we need to do the literature review and look what's out there, because it wasn't something that anybody was telling us that they were aware of in our research so far. So if we do come across some good stuff that covers both those areas, obviously we can build that into some future research. But it's a really important area, I think we've realised needs to potentially more work.
I think especially as you were talking about people in care homes living with perhaps more advanced dementia with an undiagnosed but probable cancer diagnosis, and just thinking about their experience and what support they got, what pain relief they got. You know, if you don't have a cancer diagnosis, do you get access to the medications that's going to take away some of that pain? So I think maybe that's where that question came from, and sounds like you're going to come back in a couple of years and tell us about the research on it.
Hopefully, yes. Yeah, I think, if there's some good research out there, then great. It's not something I've come across. I did a bit of a scout about recently to see if we should do a literature review on this. And there's been a couple of studies recently just around end of life and cancer care and palliative care for people with dementia. So I think there's enough to do a review, but I'm not sure what it says just yet. So it's obviously an area that people are recognising needs addressing, and I do think it is a specific need. It's not the same providing palliative and end-of-life care, I don't feel, from the research we've done so far, for somebody with dementia alone compared to cancer and dementia, and likewise for somebody with cancer who doesn't have dementia. I think there's going to be additional things within that complexity that probably link back to a lot of the issues we found in that early phase of the assessment and diagnosis, the decision making, the involvement of families, and particularly in care homes, if people don't have families, how that works for care home staff who may have to be making those decisions with GPs if people don't have particularly involved families. So it becomes quite a complex picture. But obviously people with cancer and dementia cover a full spectrum. So you might have somebody who's in their 90s living in a care home with no family members, and you could have somebody who's in their 60s who's living at home with a spouse and has adult children or whatever involved. So it's a very broad spectrum of people, and obviously lots of different cancer types and different dementia types and other comorbidities that people might have. So these are a complex population that I think that complexity needs looking at more.
I think so. I mean, even just that example of somebody in a care home with cancer going in for treatment and just how that was going to happen, and it couldn't be a care home staff member that went with them and they didn't have any family, you know, just that for that one person just sounded incredibly complex. And how do you make sure they get the right treatment, that they feel safe, they're secure?
Yeah. And who, you know, at the end of the day, it came down to who pays for that, and nobody knew who paid for that, because the primary, you know, the GP practice was saying that's not us. Secondary care was saying, well, that's not us. Social work was saying, well, that doesn't fall under our remit, and it's not that. So who pays for it, and where do you find a person to do that? You know, so there are these cases where, you know, people fall between the gaps because they're nobody's responsibility for ensuring the medical care of somebody in secondary care as an outpatient who is living in a social care situation. And, you know, I'm sure there'll be examples of people who maybe aren't in care homes but are living alone in the community who are missing out on, you know, diagnosis and cancer treatments potentially because they don't have that support in place. Because, for example, you can't have chemotherapy unless you've got somebody who's going to be around to monitor your symptoms and potential side effects, because of the risks of becoming very ill very quickly if they aren't picked up. And so there's extra concerns with people with dementia who can't report that. So if you live alone with dementia, there's a query there about whether you would be permitted to have chemotherapy, because you wouldn't have anybody there with you. So there's all sorts of things like that are bigger questions around people who don't have those support networks. And of course, there's more and more people who don't have big support networks around them within communities. So
it's huge. It's an absolutely huge issue, isn't it? I wanted to talk a little bit about, you know, you talked about the training that's available. So this is from our personal experience in Greater Manchester. Even within the hospital, just general dementia training isn't mandatory, so it doesn't happen. Or, you know, so the dementia leads over here are really struggling just to get that training out to staff members. And I wondered if you'd come across something similar in the hospitals that you'd worked with.
Yeah, I mean, I think it's the same for, you know, even for the inpatient staff, isn't it? It's unless you get it on the mandatory training list, then it's really difficult to get staff released. And even at the minute, I think with the pressures on the NHS, even mandatory training is a challenge to get people released for. So some trusts I do know have put dementia on the mandatory training list, particularly for inpatient services staff who are working on older people's wards. It's clearly not been mandatory training for people working in outpatients because they weren't aware that it even existed. But I think, you know, what you need is enthusiasm, and just mandating training to people doesn't mean they will do anything different in practice if they're working in a system that's not set up to do that. And our studies showed that, you know, it needed people's goodwill, imagination, ability to work around the systems to actually offer that really person-centered care to people with dementia and to meet those very specific needs. So if you've not got people, you know, if people aren't interested, then even if you give them the training, they're not going to do that. So I think we need these approaches that are going to be more systemic, where, you know, training is part of a bigger push and drive to ensure that what we provide meets the needs of every patient who walks through the door, including people with dementia. And yeah, so training's part of the jigsaw, but it's not going to solve just training staff won't make practice better. So I'm kind of, yeah, in a sense, I mean, and I come from a background where education and training is one of my main research areas, but in this case, I think it was part of the picture, but I didn't get the sense that if we just trained all the staff that things would happen. And actually, even without knowledge of dementia, they were doing quite a good job in some circumstances, and that bit of extra knowledge would be helpful. And I think what you've got to get from staff is a realisation and a commitment that they want to make things better, and then they'll seek the training out if they can get released to do it, in order to be able to do that. So it's a bit of a chicken and egg that you need one to get the other, really.
Definitely. Any more questions before we bring our webinar to a close? I'm just going to launch the little survey. So that just is going to drop up there. So lovely to get your feedback on today's webinar. So pop in your comments there. Sorry, Claire, it has to happen while we're all on the screen. I tried to do it like in the background, but it doesn't happen. But it's good to get this live feedback. Oh, Karen has just said, wow, how complex. So interesting. Thank you. I think it is, you know, like what you've highlighted is just the complexity around. I mean, we know, you know, our world is dementia. We know sort of the complexity around that. And then you've just added in the complexity of cancer and dementia. And what does that look like? And how do services best support people? Okay, brilliant. Everyone's voted. Lovely. Okay, well, I think we're going to bring it to an end. Claire, thank you so much for your time today. It's been really, really fantastic to find out more about your research and all of the other research that's going to be going on and that is going on at the moment. Thanks. Great presentation, Claire. Yeah, really good. If you've enjoyed this In Conversation With, we have an In Conversation with Gail Gregory on the 1st of November, and Gail is living with dementia, and she's going to talk to us about her, as she describes it, dementia chapter, and what resources she uses to help her stay positive. So that's on the 1st of November. Claire, thank you for your time, and everyone have a lovely afternoon.
Great. Thanks, everyone.